You ready? You first. Right in the middle. Oh, okay. Just a second. Just a prayer. Just pray like we do in the morning. Prayer only. Yes, that's all you got to do. And Pastor Moss is coming. That's what I told him. In that space, in that little space. Yeah. The Lord is in his holy temple. Let all the earth keep silence before him. Let us pray. Eternal God, we come into your presence this day, thanking you for the gift of this amazing day. We come now thanking you for your Holy Spirit that runs in this place. But now, God, we come thanking you for allowing us to see this amazing opportunity to gather information. And so, God, we come asking that you bless the moderators, that you bless every speaker, that you bless every person that has walked the journey to this day. And so, God, we ask that you undergird us with all of the information that we need to go out and spread the gospel to those who need the information and will benefit from the information. So, God, we ask that you move us out of the way and use us to your glory. We bless you, we honor you, we adore you. This is our prayer as we offer it up to you, thanking, trusting, and believing you to be the great I am, For it is in the precious name of Jesus that we offer this prayer. And for those who love God said, amen.
I want to take this opportunity to welcome everyone to Trinity United Church of Christ for this wonderful event, Hope in Our Hands. I want to celebrate the founder and chief imagination officer of Fertility for Colored Girls and Guys, Reverend Dr. Stacey Edwards Dunn. I remember several years ago when this idea was simply just an idea. It now has expanded to several cities across the nation, and we are excited about this conversation that you will have today. So again, I welcome you on behalf of the Village of Trinity, and because you are in the Village of Trinity, you are now a part of the Village of Trinity. So we are an African-centered congregation, and we believe that you're just coming home to your community. So I just need you to do one thing for me. I need you to find two people around you and introduce yourself. Tell them who your name, but here's the other thing. Tell them where your grandparents are from. So just go on right now. Go on, just talk to somebody. Tell them your name. Tell them where your grandparents are from. Get to know somebody in the village. Where are your grandparents from? Maternal and paternal. You may find out that you have a cousin in the house. Well, I hope now you probably discovered that you probably have some cousins next to you. There's some commonality. Again, you are part of a village. We also want to take this moment because we are live right now, and there is a wonderful community of people in Jacksonville, Florida, at the Bethel Light Church in Jacksonville. The pastor is none other than our good friend, Reverend Dr. Bishop Rudy McKissick. And we welcome those who are online right now. We appreciate you all being with us. I want to take this moment and introduce our next person who is going to share the purpose and also introduce our host. None other than, I was about to say Reverend. Monica's in seminary right now. That's what I was about to say, Reverend. First Lady Monica Moss will be bringing the purpose today. Native of Virginia and also Orlando, Florida, graduate of Spelman College and Columbia University Teachers College. And she will be bringing you your purpose and introducing one of our hosts.
Thank you, Pastor Moss. I appreciate that. Good afternoon, everybody. It's so good to see you, and especially for this occasion. Reverend Dr. Stacey Edwards L. Dunn has worked tirelessly to spread the message that those who struggle with fertility do not have to see a dead end, but an open door. And through her work, through her tireless work, and I'm really looking for her, but I don't see her anywhere. Where are you? There you are, Reverend Stacey. That helps me to see your face. This woman has created miracles in families across this nation. and probably by this point across this world, as she has brought forth information that ordinarily would never have reached the hearts and minds of people who look like us. Fertility for colored girls and guys has become an institution in this nation, and it's changing the lives of families, and she's only continuing to grow the purpose and mission of this great organization to make sure that we have valuable medical information, but she also reaches into the hearts and minds of people to inspire them to keep on hoping, keep their faith strong, and as a result, babies and children are becoming a part of families that never, ever could have seen that as their truth and their reality. So today we are here to learn. Today we are here to become greater advocates. Today we are here to lift our voices and to ask the questions that you may have about these pertinent topics that are touching the lives of more and more people as we see infertility rates that are increasing across this nation and across this globe. And to lead us today, we have a wonderful speaker today, Sister Dorothy Tucker, who you all, if you don't know her, you will after today, but I'm sure you all know who she is because she is a staple of Chicago. She's a Chicago native, and she was raised in the Lawndale communities and the Austin community. She has been a CBS reporter for many years, and what I love about Dorothy Tucker is she's about real news, not fake news. Dorothy is a person who goes for the heart of the story. She's going to dig deep to make sure we get the truth, and she's going to make sure that we get unbiased information. And whenever she does these, I consider this one of your special reports, we always leave better because we're equipped with information we did not have before. So Dorothy is our moderator today, and she's an amazing woman. I mean, we have pages of things we could say about her. But I do want you to know that in addition to being a reporter, she's the immediate past president of the National Association of Black Journalists, which is a big deal. And that means that she has leadership skills that take her into different places that ordinarily she wouldn't make it into the doors because of who she is. We thank her, and we also want to say that Dorothy, her leadership spans the local community, but also the national community. And she is doing her thing in so many amazing ways, especially with the work she does as a board member for NABJ, Chicago chapter. And she's a former member of the Northwestern Alumni Association and a current member of the Northwestern University Leadership Circle. So she will be leading us on this journey today, and we are in very, very capable hands. So Dorothy, take it away.
Thank you. Good afternoon. I'm going to take a seat here. We'll start in a few minutes, but I think first we're going to watch video. Okay.
For centuries, the reproductive capacity of Black women and men has been misunderstood and misrepresented. The narratives surrounding our fertility have been steeped in a racist and economic political agenda tied to the dark and painful history of slavery, which included forced sterilization. These traumatic experiences have not only instilled silence and shame around our bodies and health, but have led many to believe the harmful myth that those of us kissed by nature's son are hyper-fertile, mere baby-making machines. The truth is, Black women and men experience infertility and reproductive health challenges at twice the rate of our Caucasian counterparts and are less likely to access care. However, we can no longer remain silent, deny our dreams, or limit our life-giving capacity, for the time has come for each of us to shift the narrative and show the world that we matter. Our fertility and reproductive health matters. Thus, we have a message for Black men, women, boys, and girls. You matter. Your mind matters. Your soul matters. Your body matters. Whether married or unmarried, your fertility and reproductive health matters. So let us draw on the strength from our ancestors and icons, Josephine Baker, Viola Davis and Julius Tennant, Angela Bassett and Courtney Vance, Gabrielle Union and Dwayne Wade, Tyra Banks and Debrat. And remember that our children and generations unborn are depending on us to advocate for change, and that hope is in our hands.
Wow. All right. One of the things I love about this church is that they believe in educating the community. And once again, all of you are privileged to, as I am, to be here, to share this moment and to learn about a subject that, quite frankly, I did not know a lot about. So I'm going to be in this journey with you. My questions will come from the heart, from the head. And the most important thing is that it is your opportunity to ask your questions. I believe that you were given a sheet of paper. If not, raise your hand. And if you didn't get one, let's make sure that those who did not get a sheet of paper, that they get one. Write your questions down, because we want to make sure that they get answered today, and then at some point we will collect them, and before we leave here today, we will try to get answers to as many questions as possible. Now, it is my pleasure now to introduce our panelists. Please come to the stage. Dr. Crystal Clark is an internationally recognized psychiatrist in reproductive mental health. She's an associate professor in the Department of Psychiatry at the University of Toronto, the associate head of research at Women's College Hospital, and a scientist at Women's College Hospital Research Institute. Dr. Jennifer Miles Thomas, the vice chair of the Regional Integration and Innovation at Northwestern Medicine, Department of Urology. She is also the current AUA Treasurer-elect. Dr. Amanda Adeleye, a reproductive endocrinologist and an infertility specialist. Come forward, please. She is also the founder and medical director of CCRM of Chicago. Dr. Gloria Elam, gynecologist in Naperville, Illinois, has over 37 years of experience in the medical field. She is affiliated with the University of Illinois Hospital and Clinics, and our very own Dr. Reverend Stacy Edmonds Dunn, founder of Fertility for Colored Girls, the national organization for Black women, men, and couples, and she is familiar with the pain that comes with the challenge of overcoming infertility. Thank you, ladies. Thank you for joining us today. Let's start off with the basic question. What is infertility? Dr. Amanda?
What's infertility? So infertility is the inability to conceive. It's traditionally been described as when a heterosexual cisgender couple tries to conceive for about a year and is unable to. However, more recently, the American Society of Reproductive Medicine, or ASRM, has expanded that definition to include really anybody who needs help conceiving, specifically medical help conceiving. So that can be people that are part of the LGBTQ+ community, or people that want to be single parents by choice and need reproductive assistance. All of those folks would be included as people having fertility issues that warrant medical treatment.
Thank you. Reverend Stacy, you have experience in infertility. Can you summarize, share your story with us, if you wouldn't mind?
In 2007, my husband and I, not too long after getting married, we proceeded in attempting to get pregnant, and to no avail. We did not. And so about 6 months after that, we decided to go see a fertility specialist where we would both be diagnosed with infertility, myself with unexplained infertility and him male factor infertility. And so we were both very shocked. I was shocked because I thought that I didn't know that Black women could experience infertility. And it wasn't a conversation that we had in our community, but I would find out that day very different. And the doctor told us at that doctor's appointment that if we indeed were going to get pregnant, our best option was IVF, and it would be $25,000 because at that time, insurance was not going to pay for it. And so that day, it began at that time, it became a 7-year fertility journey. Throughout that time, we went to Barbados for IVF vacation, we did not get pregnant there. We came back here. We had multiple doctors. By the time we made it, I'll fast forward to about 5 years in, after 5 in vitro cycles, I finally connected with the doctor that said, I want to do some more exploratory work and put you to sleep and find out what is going on. And so she did, and I would come out from that procedure, and she would say to me something no one had ever told me, which I believe was oversight and malpractice, that I had one fallopian tube and I had a unicornate uterus. That no one told me at the first, when I went through testing 5 years ago. And so she said that could possibly be why you have had so many negative pregnancy tests, and it's the cause of your infertility, and could have been $100,000 later, that they were placing embryos in the wrong place. And so she was like, now we know. And she was the first doctor who would personalize my journey, get specific equipment to use for me, the first doctor who would also do a mock transfer. Fast forward 2 years later, at 43 years old, I would finally get pregnant with my daughter, who is now 10 years old, with my 7th in vitro cycle. 7 years later, after 3 frozen transfers, I would get pregnant at the age of 50 with identical twins who are now about to be 3 years old. And so that's, in summary, a little bit of my experience. My experience was filled with, it was an emotional roller coaster. I would not wish infertility on my worst enemy. It was, again, it wasn't anything that I wanted to talk about. Most people who experience infertility, we don't find ourselves talking to a lot of people. And as a result of the fact that there was no space, no safe space for me to talk to anyone, that is one of the reasons why I founded Fertility for Colored Girls, so that there would be a space where Black women and men would be able to express and share their authentic experiences on this particular journey.
I have so many questions. With you alone, we could just do 1 hour on you alone. But within this time, we will talk about the racism that you experienced, the emotional trauma that you went through. But my first question to you is, what kind of conversation were you having with God all this time?
Well, in the beginning, I was still very hopeful. I was sharing with someone the other day that I think that I experienced my greatest sense of devastation at IVF's number 6, when I actually got pregnant and lost the baby. I was asking God, why me? Is it, am I not supposed to be a parent? That sometimes that went through my mind. However, there was deep within me a sense of hope, and a sense of hope that I would become a parent, because all my life I have wanted to be a parent. And so I knew that some way and somehow that I would become a parent. And I think that I got to a point after wrestling with God. God also began to tell me that it wasn't about my time, it was about God's time. And that there was a time in which the child that God had promised me was supposed to come into the world. And this was not all about me, but this child that God had promised me was going to be coming into the world at a particular time. I will finally say that one of the things that I had to come to the resolve with was that I wanted to be a mother, and I didn't care how I was going to become a mother, and that it wasn't about me birthing a baby, it was about me becoming a parent. And I had to come to that resolve that there were multiple paths, and any way that the Lord wanted to bless me with a child, I would be satisfied.
I have to believe that, there are so many times that you turn to the Bible, that you turn to the church, And, we will talk about that again as well, because I know that's what we need to hear. But Dr. Crystal, for you, what is the emotional trauma like? And when this happens, what happens to the couple?
So that's a complicated question, but I'll back up a little bit just to educate everyone that mental health during the infertility process is different for Black women, in that we are already twice as likely to have infertility problems, and we are more likely to also experience depression, anxiety due to intergenerational trauma and all of the trauma exposures we've had, so racism, abuse, emotional challenges in our life. And when you compound that with the idea that, yeah, we should be fertile. I mean, we are Black women. We should be fertile, but I'm not fertile. Why am I not fertile? So that compounds the shame and mental distress, and increases the risk of depression and anxiety. But on top of that, you add in the male factor, and the couple, particularly Black couples, are struggling with, well, what's wrong with us? And how do we overcome this? And why have we been forsaken? And why are we having these challenges?
Can I ask a quick question? So, coming as a urologist, we see mostly men, but there's still that large stereotype that our men are strong, fertile. It's that historical stereotype. So, how does it kind of impact the men?
Mm-hmm. Yeah, so it impacts the men. We don't talk about mental health enough in the Black men, right? This continues to be a huge stigma in our population, not just amongst Black women, but specifically amongst Black men. And so what I see is a lot of suffering silently amongst the Black male population.
Because they don't want to talk about it.
Because they don't want to talk about it, but also they don't want to hear that it's their sperm, if that's the case, or that they're the reason that their partner isn't getting pregnant. Because they are supposed to be strong Black men. But the women don't want to hear that either, because we've always been told we're strong Black women. We are super fertile. We should be able to get pregnant when we want to. So the shame is really significant. The guilt is very significant, and that's compounded on our intergenerational trauma and our higher risk for depression and anxiety due to social determinants of health.
All right, so listen to these facts.
Okay.
9% of men of reproductive age in the U.S. experience infertility. For 1/3 of infertile couples, the difficulty is caused by the male partner. Black men have the highest infertility rate at 13.2%, with Hispanic and Asian men showing 12.8%, white men 11%. And this is the part to your point. Only 1% of men seeking infertility treatment were Black. Why? We've touched on it, but why won't Black men seek help? Are we talking just all pride here?
Well,
Go ahead.
I will answer and then pass it on to Dr. Jennifer here, but it's also society norms, right, and cultural norms, and how we have approached mental health in our community, which we don't talk about enough. We have not normalized seeking help for Black men in a way that would make Black men go out and seek help. But there's also a lack of representation. Who are they seeking help from? There are not many Black therapists, psychiatrists, counselors. There are not many Black urologists. So that's a huge gap in our medical system, but it starts with us and us destigmatizing and decreasing the shame around this issue.
So I would say in my experience, there are a lot of barriers. First of all, most people don't know about urologists, right? Unless you have someone who has a history of either like erectile dysfunction or stones, you don't even know what urologists do. Also, a lot of times, there's a lot of conversations about women, and we really don't understand the sheer number of men that have infertility problems. And historically, like through high school and college, if someone's very sexually active and no one gets pregnant, the first thing on their mind isn't, oh, I may have an issue. It's, oh, I didn't get somebody pregnant, right? So we're just going to be real. The other thing is that it costs money, right? None of this is free. A lot of it hasn't been covered or by your employer or by any other plan for a long time. So the idea of a man seeking out additional care is not something that we've normalized. A lot of times we are the ones who are like our boyfriends or our husbands or us need to go out, something's wrong, you need to go see somebody. And a lot of times we're making those appointments and we're going with them to those appointments. Some of it's stigma, something's wrong with me, something shouldn't be wrong with me. But from our standpoint, it's if you actually have infertility, we need to make sure there's not something else going on. And this is actually a sequela or a consequence of something else that's systemic going on in your body. So you need to be fully evaluated. But I think there's so many reasons why, and hopefully we can start changing that message.
Dr. Gloria, for women, what are the causes of infertility?
Yeah. So often there's not one specific thing, but what impacts the Black women population are fibroids and endometriosis. And so oftentimes people don't know or are not aware that this is a problem or could potentially be a problem. Sometimes they're with physicians who go to the last solution, which is you need to have a hysterectomy, you have fibroids. If you have somebody telling you that, go find another provider.
Say that again, because I know so many of my friends, unfortunately, have had hysterectomies because of that.
Yes.
And if they say what to you,
If
what
they
do you
say
need to do?
You know, you need to have it, you're having too much bleeding, you have too much pain, just get a hysterectomy. Say thank you and go find another provider. There's so many options, there's so many treatment management things that can happen, that can be modified, lifestyle included, that can solve that and overcome some of the issues with infertility. Not all the time, but you know, that's not the first step. Sometimes it's anovulation. So people aren't releasing the egg every month, either because they have polycystic ovarian syndrome. Weight is a lot of factors with that. And so that keeps the person from being as fertile. So they're subfertile. They're less likely to have an egg available to get pregnant each month. And so people, all of us know somebody who got pregnant and wasn't trying. But really, there's only about a 36-hour window per month that you can get pregnant, believe it or not. And so if the egg is not there at the right time and the sperm doesn't meet the egg at the right time, they're going to be infertile.
You mentioned sometimes it causes weight. So let's talk about those other factors into all of you. Drugs, alcohol, marijuana. How do those, do they contribute to infertility?
I can take that. Before I do, I just had a quick question. How many people know what a reproductive endocrinologist is? Amazing. Oh, like half the audience. That's great. So I didn't actually know until I was in residency. So I'm an OBGYN by training. So 4 years for that after medical school, and an additional 3 years specifically thinking about hormones as it relates to the reproductive tract. And the bread and butter of what I do is in vitro fertilization, which you might have heard of, which is in the news. So I like to just say that because sometimes it's like, what's an REI? It doesn't even, sounds like a store. So to the question of, what are the factors in terms of lifestyle that might affect our fertility, there's excellent data that smoking can impact fertility. So whether it's a man or a woman, smoking can increase the time to pregnancy in people that are trying to conceive on their own. It decreases the ovarian reserve, the number of eggs that you have. You're born with all the eggs that you're ever going to have, so you have to treat them well. And something like smoking will reduce the number of eggs you have to the extent that actually people who smoke tend to go into menopause about a year earlier than their non-smoking counterparts. In terms of alcohol, moderate to heavy alcohol use, which that exact term is debatable, is also associated with a prolonged time to conception. Marijuana is a tricky one. There are some data out there that suggests it might impair fertility, particularly in men. There's good data that when you look at the sperm under the microscope, and actually you might be able to comment on this as well, the motility, the way the sperm moves, is not as good. However, when we look at the data surrounding do people who smoke marijuana X amount per day, per week, per month have an issue conceiving, it's a little murkier. And I think it might have to do with, what you're smoking or how you're consuming marijuana, how frequently you're doing it. So we're just not quite there yet in terms of being able to say exactly what's the effect of marijuana. And as for illicit drugs, certainly they can affect your systemic health, and depending on the frequency of use and other risk factors might also impact your fertility.
And for men, it's very similar. So the way that men make sperm is they make the sperm in their testicles based upon certain hormones that come from the brain to activate the testicles. Then the sperm have to go through the system and all the way out. So in the system, there are little hairs that move everything through, and sometimes those hairs can get disrupted by drugs or illness or infection and things like that. So very similar, we found that diabetes, hypertension, tobacco and smoking, exposure to certain metals and dyes, and if someone works in an industry, definitely have an impact. We've also found that age has an impact, especially for men greater than 40. Obesity also does. So in our world and what we see with our mates, our husbands, our friends, is we see a lot of chronic illnesses. We see diabetes, we see hypertension, we see obesity. Certain medications, especially ones for the prostate, can sometimes slow the motility of the sperm, because in our world, it's just not the number, it's what we call the quality of the sperm. It's how many are swimming and how many look normal. That makes the world a difference, because you only have a small window, and they have to connect, and they have to be normal in order to connect.
So on the flip side, is there something that both men and women can do in terms of what they eat, how they go through life, how they exercise, to increase the chances of them conceiving?
So I'll go first. There's actually data in the urologic literature that says that there is no supplement. So if anyone's buying things right now, okay, I guess we are, but
when you say supplements, like vitamin supplements and
vitamins, anything that you would Google and say, can I increase my fertility? It doesn't work.
None of it works.
In our experience, and we've recently done a systematic, which means they looked at all the literature that was out there, and there was no evidence that we could say this one thing or these two things will work. So a lot of things that are marketing, it's a lot of wishful kind of thinking, but no. In our world, we say living a clean life. So staying active, drinking mostly water, eating a clean diet, not foods that are high in fat, nothing that's, I would say, if you could grill or you could bake, that would be less nitrates, which means as you burn certain foods or you flame broil them, you can create certain, quote unquote, I'll just say toxins. It's not as clean as if you bake or if you broil something. So I think there's a lot of small things we can do to make ourselves overall healthier.
From the woman's side, or from the kind of ovary side at least, I would say it's complex. It's going to depend on the underlying reason why somebody's having an issue conceiving. So as an example, like if your tubes are blocked, there's no diet that is going to fix it. And I think the most important kind of lifestyle behavior in my view is education, which is what Reverend Stacy has been so great about. Because I think if you are aware of your fertility, aware of the fact that you might have infertility, and seek medical assistance in a timely fashion with the right person, you're going to identify the underlying issue. So that is the best kind of behavior you can have. Separate from that, certain conditions might actually benefit from lifestyle changes. As an example, as Dr. Gloria had said, if you have polycystic ovary syndrome, or PCOS, you tend to, not always, but tend to be of a higher weight. And in that group, losing about 5 to 10% of your body weight is associated with an increase in the frequency of ovulation, of releasing an egg. And so that alone could improve your chances of conceiving. But on the other hand, if you don't have PCOS, weight loss is not clearly going to improve your chances of conception. And again, I say education is so important because I don't want somebody who's been experiencing infertility for 4 years to go spend 2 more years trying to lose weight, and then they turn around and they're 43, finally coming to see me, and also not having lost that much weight, because it's very hard to do, and having the same problem that they had 2 or 3 years ago. So yes, absolutely. Similar to Dr. Jennifer, I think it's very important to live as clean of a lifestyle as you can. I like to tell my patients, you know, imagine you're already pregnant, right? Like, what are the behaviors you would do if you were pregnant? Do that now. You're laying the foundations for that embryo, for that fetus, to have the best opportunity possible. But
So that, for me, that would be Haagen-Dazs ice cream.
fabulous. You know what, if it brings you joy once a week, I think that's great.
I want to talk to Reverend Stacy again for a second. Go back to you, because you guys were talking about racism a minute ago. You said you felt like, you know, that you were the victim of racism. What happened, at what point, and why did you feel like you were being treated differently because of the color of your skin? How?
Before I say that, I want to say really quickly to preparing our bodies. I think as young girls, many of us were told everything about what not get pregnant.
Yeah.
And I think that the message that we need to teach our young girls is how to prepare your body for pregnancy when you're ready, so that they are eating well now, that they are taking care of themselves now, and even our young boys as well, that they're going to the doctor for checkups now, so that when they are ready, hopefully their bodies will have a stronger foundation to be, to conceive. For me, I think that there were a number of places that along my fertility journey, and even during my maternal health side, I remember one of the reasons why we went to Barbados is because we wanted to make sure that Barbados was $7,500 for treatment versus the $25,000 for treatment. And so when we made the decision to do an IVF vacation, we wanted to make sure that we were going somewhere where they were used to working with black and brown bodies and also had great success. So we went there where we did not experience any racism. But when we came back here, and actually the first doctor that I went to here for treatment, we began to experience racism at the front desk, how they treated us at the front desk, as if, why were we there? The questions that they would have, how they would act, and what they would ask us, how they would treat us, as if we really did not have a place in being at the doctor. And it wasn't the doctor, it was more of the staff that was not trained and equipped to care for people of other ethnicities. And so I think that's what I experienced there. When I was in the hospital, particularly with Shiloh, one of the challenges that we experienced, I had basically a perfect pregnancy. And it wasn't until I got ready to get ready to deliver Shiloh that my blood pressure went up. And I was, the doctor that was on call was an African-American doctor. And the nurses had been in to check me, and they said nothing about my high blood pressure. Nothing at all. And it wasn't until the doctor brought it to their attention that they began to move and accommodate me and make sure that I had the necessary medication so that, myself or my child would not have any challenges. And so, and I also, if I go back again to 2007, when the technician who did my test checked my uterus, made sure, they told me that I had 2 fallopian tubes that were open in 2007. And in 2012, I would find out that I had one. Now, I know in 5 years, fallopian tube didn't disappear. But I think that it was oversight, malpractice, and then I also think that they did not take me seriously, which is what we find a lot of times in many doctors' offices, that sometimes, oftentimes, not all the times, but many times, people do not take African American women and African American men seriously.
What are some other situations that black women, black men, couples can find themselves facing racism that the rest of you have seen or heard?
Some of it's just getting referred. You know, they'll just continue, well, just keep trying, and not getting referred to gynae for one, reproductive endocrinology. And so then again, the time passes along, and it is harder as you get older. Those eggs are older, so the quality has gone down. The eggs aren't as responsive to the hormones that are being sent from the brain. The ovary just cannot do what it used to do. And so that delay makes a lot of problems. We have, some of the clinics are booked out 2 years when people could have already started part of the workup and processing, but they'll put them into another clinic that's 2 years out. And so now somebody who could have been getting treated at that time, 2 years older.
I would also add that what I see with my patients a lot is that there's a lack of access, and I'm not just talking about access just getting to a doctor, but also once you get to that doctor, does that doctor give you the information and the education you need to make informed decisions and decisions that are best for your journey? And often, even if someone gets to the doctor, the couple gets to the doctor, they're not getting that education, or they're getting bad information, like Dr. Gloria was saying, where, oh, you have fibroids, so get a hysterectomy. There's no discussion about, well, do you want to have children? How might we do this differently? What other measures can we take? Really understanding that patient and that couple's journey and what they're interested in. We are seeing so many financial barriers, of course. Infertility
And how
treatments.
much typically does it cost?
varies.
You mentioned $25,000. Is that for the year? Was that for one time? Is it just for
One cycle,
One
and that can
cycle.
include medication. That includes medication and the cycle itself.
And is that typical, 25,000?
Can I clarify? Yes, so for intrauterine insemination, where the sperm is placed into the uterine cavity, it typically runs somewhere between, in the United States, $500 to $4,000. However, in my experience in the Midwest, it's more like $1,500, including ultrasounds and medication. Intrauterine insemination is effective about 10% of the time, which, believe it or not, is pretty good for a non-invasive or very low-invasive procedure. In vitro fertilization, IVF, where the egg and the sperm come together in the embryology lab, is a very complex process. In the U.S., it's estimated to be between $12,000 to $20,000 typically. In my experience in the Midwest, it's probably going to be more like $15,000 to $20,000. And then there might be some additional add-ons depending on your specific needs, or perhaps you might want genetic testing of the embryos. That's typically an additional $3,000 to $5,000 depending on your situation. So there's a lot of variation. There are reasons for some of that cost, but typically, yes, it's going to be $15,000 to $20,000. And I think that Reverend Stacy's experience is not atypical.
Go ahead.
Yes, part of our guidelines for treatment are that the male and female should be tested concordantly, which means at the same time, because you see the costs involved. Sometimes, if it is male factor, it's much cheaper. All we need really cheaper. So because well, not on the female side, on the male side to do the evaluation, because what we're looking at is the semen. It is less than $100 to get a semen analysis, to get the results of that. There is other testing we can do depending on what that actually looks like. So we're looking for a certain number of sperm. We're looking for the shape of the sperm. We're looking for the motility. And all of that comes on one report. That helps us localize what the problem is and to see what the options are on the woman's side.
So if that's the case, it would seem that if you are having issues conceiving, he should go first.
Well, our guidelines are that both should happen at the same time. That's what I will say.
Yep. Yes, no, I
I mean, if it's cheaper.
Yeah, I think the same time is definitely appropriate.
But
Just
I mean,
because
even if you're there at the same time, I still think he should go first.
yeah, unfortunately, the
Okay,
majority of the
I'm
time,
only kidding.
there's a female issue, so it's good for both to be evaluated. I will put in a little PSA out there. If you're not aware, there are now at-home testing kits. Fellow is CLIA certified, so like certified with the FDA. It's pretty amazing. There's also Posterity. You might know of a couple others, but if this is a challenge that you're experiencing, perhaps with a partner, you can now actually do testing at home in the privacy of your own home, which can really help with some of the stigma, which can be another barrier to accessing fertility care.
So talk about cost. You talked about cost. I mean, does insurance cover any of it?
On the male side, it does, and some of those.
Another reason he should go first. No.
That is not exactly what I'm saying. So Fellow itself, it's not that expensive. It's a couple $100. And then Prosperity is also not that expensive. So if someone is not interested in immediately seeing the doctor, there are a lot of things that you can do online, get the kits at home, and test just to get a baseline. You still will need to see a doctor. It's not like I can just you can't spit down your own sperm, like honestly, you can't. So you'll still need to see a doctor, but at least you'll have a better idea of what's going on.
But again, the insurance, I mean, once you have to go through is $25,000, is that out of pocket? Is that $4,000 out of?
I'm so sorry, Dorothy. This is like my favorite topic. I'm so sorry. I will take 2 minutes and no more. Okay. So in the United States, even though from a medical perspective, all the doctors up here, we would say infertility is a disease, it is not standard for insurance to cover infertility care. However, there are several states at this point, 22 states in the U.S., where there is a mandate for fertility coverage. What that means is if you have insurance through your employer, so there's already caveats and loopholes here, but if you have insurance through your employer and there is a state mandate, that insurance is required to provide you with coverage for your fertility care. So there's a variation in what that means. As an example, in California, one of the most liberal states in the union, it wasn't until 3 or 4 weeks ago that SB 729, this bill passed requiring employers to cover infertility care, including IVF. Up until then, diagnosis was covered, which is great. That still is going to help with access. But okay, so maybe you know that you have issues getting pregnant, but then you're stuck with a $25,000 bill. So it doesn't help that much. So there's a lot of variation. However, Illinois is a reproductive haven. It's pretty incredible. And if you live in Illinois and your employer is based out of Illinois, you likely have fertility coverage, often including IVF. And if you don't, it is a good time to talk with your HR department about this. One big glaring loophole in my mind is, unfortunately, Medicaid does not cover infertility care, and that has to do with the fact that it is somewhat federally subsidized, even though it's a state-implemented insurance. So this is why, personally, I think it's incredibly important to be involved and vote and make your voice heard, because we can change this. There are bills out there. Senator Cory Booker has a bill about covering IVF. Senator Duckworth from Illinois has a bill about protecting IVF access. People are talking about it, but it's important for us as constituents to speak up. That said, the short answer is yes, you can have coverage for infertility, and we're very fortunate in Illinois, but it's not perfect, and most people would still say that even with insurance coverage, there are gaps, and people do pay out of pocket for maybe medications or something.
And I would just want to add on to what you're saying, Dr. Amanda, especially since you mentioned the spectrum, just to highlight to everyone, talk to your HR department about how much is covered, because it varies from insurance to insurance, even in states where coverage is the mandate.
Or there may be limits. So they may say you have 4 cycles. And so if they didn't work for various reasons, then you're going to be limited to the cost.
Is there a typical number of cycles? Does it take the average couple 2 cycles? Is it 5 cycles, or is it like all over the place? And you're all laughing at me. Okay, so go ahead.
Yeah, it depends on the reason for infertility, like why you need it. To level set with in vitro fertilization or IVF specifically for people under the age of 35 in the U.S., Nationally, success rates are about 40 to 45% per IVF cycle, including the transfer of an embryo fresh or frozen until all embryos in that cycle have been used. And I know that that might be a little bit technical. I'm happy to dive into that later. But an IVF cycle can be generally effective in your mid-30s. By the time you get to your mid-40s, we're looking at maybe like a 10 to 12% chance of success per IVF cycle.
So outside of IVF, are there other treatments? Are there other things that, you know, if you find yourself in this situation that you should consider?
So there are other treatments. So sometimes it's just the ovulation, making the egg available. So that usually is treated medically. There are some oral treatments, but there are also some injectable treatments depending on what the needs are. So some of that's covered, some of it's not. There are some discount prescription tools that can be used for couponing, to get discounts on some of those medications. There are other options. Again, if someone has chosen to be a single parent, they may go to a sperm bank and look through a catalog with kind of characteristics that they are interested in, that being the sperm contribution, and purchase the sperm that they can either inseminate at home. There's some home kits, or they can go into a reproductive endocrinology office and have the insemination. So you're providing that other half of the chromosome makeup for that child. So that can be purchased, and covered variably over time. And then other options for adoption, whether you're going through private adoption, whether or not you're going through more of the state-sponsored adoptions, those have variable costs with them. And then surrogacy. So surrogacy, sometimes a uterus is not available, it's not working well, various things, and may be absent, but the eggs are still there. So you can use your eggs and your partner's sperm or the donated sperm, and then someone else is carrying that pregnancy, but that is actually your biological child.
I would just add, bringing it back to mental health, it's so important to be mentally well pursuing this process. I'm often the one, as a psychiatrist, signing off on, can someone proceed who has a history of depression or anxiety or some other mental illness? And when we talk about the behaviors such as smoking or use of marijuana or drinking, a lot of that is self-medicating because of a mental illness, because of the daily stress that we're experiencing in that undiagnosed mental illness. And untreated mental illness decreases the rate of fertility as well.
I have to believe that this is a very, as we've said, emotional time, challenging time for the couple. What advice would you give women and men when they are going through this process? What do they need to do to make sure that they are staying together, that they are keeping the marriage strong, that this is just not something that is just tearing them apart? What advice do you give them?
Well, when we're talking about mental wellness, I am thinking, I often say, let's be preventative. Let's go ahead and seek therapy. I really believe that going through this journey, everyone could use a therapist to give them coping skills, whether that's mindfulness, how to stay grounded, because it's a very anxiety-provoking process for many. It can be very traumatic when you're having pregnancy losses or failed trials. So just being able to just work through things mentally and process things mentally is so important as a couple. Having your inner circle, a very strong circle around you, whether that's your folks at church or family that you trust and confide in, close friends, that support circle is extremely important. And it's also important to keep those other folks out that are not, positive or just don't know how to support you.
Should you take a break every now and then? Or do you advise couples to keep trying, or?
I think, can you hear me?
Yeah, just.
I think that I think.
I think
Yes. Whether it's couples, because sometimes we have couples that are going through these processes, but we also have unmarried persons who are undergoing experiencing this journey. And so I think that it's per individual. You have to decide when to stop and when to keep going. I know my husband and I, there were a number of times in our journey, instead of just doing cycle after cycle, we took the time to breathe, to pray, to regather, to recenter. And I remember really before, when I had that sixth miscarriage, I had that sixth IVF and I lost the baby. My husband, I was like, well, let's just move toward adoption. And so we did set up a meeting, a consultation with an adoption agency. And after we met with them, my husband said to me, he said, I think we need to take a break. And I think we need to take some time and pray and just be with each other for a while. We've been through a lot. And he said, we need to sit and go to God and ask God for direction regarding what we should do next. And that's what we did. And we did that a couple of times. But this particular time when we did it, it was a little different. And after we came up from a season of prayer, my husband said to me, I believe if we do it one more time, this will be it.
Wow. Wow. That's powerful.
And it was it.
Yeah.
And he said to me, I said, well, we're going to have to pay out of pocket this time because a couple of times the insurance did decide they was going to accommodate us. He said, it doesn't matter. He said, I believe that this will be the time. And the seventh time was it.
Okay, we're going to move to some questions from the audience. Great questions. If you do have one, you can bring them up. So here's a question. Are there tests to directly tell women that they are fertile?
So the question is, are there tests to tell women that they are fertile? Unfortunately, no. I'm pretty evidence-based, which means like I try to read research studies and really see what they say and follow guidance before really making a recommendation. So it takes a lot for me to say anything with certainty, and that also comes to fertility. So I will tell patients in my office, I cannot guarantee that you're going to be pregnant someday. I cannot. The only person who knows that is you and God, right? Like, I don't know that. But there are some clues that there might be a significant problem, right? If your ovarian reserve, the number of eggs you have is very, very, very low, and you're not ovulating in a predictable fashion, that might suggest you're kind of at the end of your reproductive timeline, which may or may not be in your 50s in terms of the number of eggs you have left. Or if, there's tests that show both of your tubes are blocked, it's going to be very hard for you to conceive, right? So there are tests to show that there might be a problem, but it's very hard to prove that somebody's going to be able to get pregnant in the future or guarantee that. And so I think if it's very important for you to build your family, you need to talk to your OBGYN, talk to your doctor, talk to an REI. If this is really important to you, start thinking now about how you're going to build that family.
Speaking of OBGYN, can you address the impact of various forms of birth control on fertility? Is there a connection between infertility and birth control?
So generally, there's not a long-term impact. Most of the things that you're taking daily or that are insertable, once you're not taking them, your fertility rate turns to whatever it was going to be. Sometimes people forget that they got on the birth control pills because they had irregular periods. They were not ovulating in the first place. So when they stop taking them to try to get pregnant, they go back to that anovulation again. So they've forgotten that there was an issue going on before. So in general, it doesn't impact it negatively once the IUD is out, once the Nexplanon is out, once you're not taking the oral contraceptives, it reverses fairly quickly. The one that's a longer term is the Depo-Provera injection. It's in your muscles, so it takes a long time to get out of your body. So if you want to get pregnant quicker, that's not the method to use. But again, this is not having any complications because, of course, with the IUD, you can have an infection. The infection can impact the tubes and things like that. So this is, straightforward. Nothing's happened. Usually there's no long-term impact. So one other thing I would say, though, is timing. Sometimes we get lulled into a sense of security of, oh, I want to do this, and I want to do that, and I want to do this, and then I'll get pregnant later. And the clock does tick. It really does tick. Now we see, different from Reverend Stacy, she has success at 50, but she was doing things not naturally. She was going through the IVF and everything. Sometimes on these movie stars, we see that they have, babies at 50 and 52. They either stored their eggs early, or they're using somebody else's eggs. They're not spontaneously getting pregnant. It's not our business. It's not for them to tell us, but we shouldn't be lulled into the sense of, oh, I'm going to try to start getting pregnant when I'm 48, 49.
If you have fibroids, will it be hard to conceive?
Possibly. Depends on where those fibroids are. Fibroids that are in the uterine cavity, which is where the embryo wants to implant, are a big problem. And they can make it harder to get pregnant, harder to stay pregnant, and increase your risk of miscarriage if you do get pregnant. So those need to come out. Fibroids that are in the muscle of the uterus, it's debatable. Probably if they're on the smaller side, they don't have an impact. But if they get very large, there's some debate within our community about whether or not it does impact the ability to conceive. Some good news is having a fibroid removed in general, if you go to an excellent surgeon, should not negatively impact your ability to get pregnant in the future. So it's really important to have a relationship with your OBGYN, somebody fantastic like Dr. Gloria, who's going to go through all of your options and details when it comes to fibroids.
Reverend Stacy, this is for you. Knowing the importance of voting, how would Project 2025 impact the work of this organization and the health of Black women?
Well,
It's just you.
testing. I wish I had the book we just received today in church. As Pastor Moss said, I think it was about page 396 or so, that as a part of Project 2025, they are seeking, I'd rather quote it if we can.
Yeah, I was going to also follow up and ask a question about Roe versus Wade.
So ask that so I can then pull it up, because I want to make sure that we're providing correct information.
There was a referendum when I voted on Thursday about IVF coverage, and I was appalled because I hadn't heard anything about it, and I thought I was researching everything that we had to vote on this year, so I was really surprised. So if you haven't voted yet, make sure you look for the referendum that's on the Cook County ballot.
100% I agree. I was like, where did that come from? Basically, it's voting to say that you agree that IVF access should be available for everybody. To everybody who has insurance, it also covers pregnancy, which is like all insurances cover, your pregnancy. So I would recommend voting yes, if you have the opportunity.
All right.
So Project 2025 would restrict sexual and reproductive health and rights. And so we already know that Black women and men already are less likely to seek access. So if it would restrict reproductive health rights and access, it will impact our ability to be able to become parents. And especially as Dr. Amanda stated, that we only have 22 states already in the United States that provides health insurance and access. And so if we restrict it, and we are already a community that is experiencing infertility and reproductive health challenges at 2 and 3 times the rate as our Caucasian counterparts, there is going to be issues. Someone just talked about fibroids. I don't know if you know, in our community, Black women experience fibroids at 7 and 8 times higher rates than other ethnicities. Our young girls are beginning to experience fibroids at as young as 12 years old. What happens if there is no access to reproductive care? What if someone does have an ectopic pregnancy and they go to the hospital and they need to have a procedure? If they cannot have the procedure, they may die. What if someone has a stillbirth and needs to have a baby removed? If they cannot have access, it will impact the Black woman. And so I think that we have to be mindful, again, that democracy is on the ballot and our reproductive health care is on the ballot, and our rights and our ability to even control our own bodies and not having some white man to decide what we're going to do with our bodies, because men are making these decisions around our bodies. And so when we think about Project 2025 and what is at stake, those things are at stake.
Keep the mic, and let's just segue right into just what your organization is doing and how the community can help, how the church can help.
Yeah. So Fertility for Colored Girls, as you heard, we are the national organization for Black women, men, and couples who experiencing fertility challenges. Right now, as we have been doing since 2013, we are trying to raise awareness, because this is a huge issue in our community. This is not a white woman and a white man's issue only, but we are experiencing challenges. I would dare to say that one of your friends, everybody in here, has someone in their family that has experienced fertility challenges. Our goal is to ensure that there are safe spaces for us to have conversation, to raise awareness around the issue. One of the things that we just received a grant from the American Society of Reproductive Medicine to do a documentary next year. And this documentary, thank you. In this documentary, we were the only African American organization to receive this grant. So this is really big. And so this documentary will help us to raise awareness around the issues of infertility and reproductive health in the Black community. In addition to that, as a part of this documentary, there will be a curriculum that will travel with this documentary that will help faith communities, also communities of color, as well as fertility clinics as well. You should have received a letter when you came in to Tammy Duckworth. One of our goals is to establish a national week called Black Infertility and Reproductive Health Care, where we will take the time to shine the light on Black infertility and reproductive health across the country. And we need your help to do so. And one of the ways that you can help us is to sign that letter so that we can get a resolution on the floor, so that we can establish this week of Black infertility and reproductive health, so that we can continue to raise awareness and ensure that our children and our children's children will also not only have access to care, but also access to information. If you want to know more about Fertility for Colored Girls, we ask that you would check out www.fertilityforcoloredgirls.org. Follow us on Facebook, Instagram, and please make sure that you sign the letter for the letter campaign. And then you can also share your story on our website as well, so that we can impress upon legislators just how important this issue is. If you are experiencing infertility, you can also contact us through our website, as we have a support group here in Chicago. Some of our leaders are here, as we do in 17 other states as well, so that you can have a community to talk to, people to buddy up with you in as well. And you can also learn about the number of resources that are available, from grants to also doctors that will be willing and able to serve you rightly.
Thank you. We're going to come back and talk a little bit more about what the church can do, but let's take a couple of more questions. I've got one that I want for you, but before that, this is a good one. What are the physical impacts of trying multiple rounds of IVF?
So what are the physical impacts of doing IVF? So overall, I mean, in the first part of an IVF cycle, you're using injectable medications to stimulate the ovaries to mature more eggs than would be typical in a menstrual cycle. You might get some injection site reactions, some soreness, some bloating, some mood changes. But overall, it's pretty self-limited. There are some rare side effects or adverse effects where, like, the ovary can get so large it can twist on itself and cut off its own blood supply. That's called ovarian torsion. That's a surgical emergency. That's extremely rare. From the egg retrieval itself, there's the risk of bleeding, infection, injury to the bowel or bladder. I say it like that because it's extremely rare. It's a very, very, very safe procedure. You know, the folks that do this should be board certified reproductive endocrinologists who have expert hands in doing this. So in general, there are not a lot of long-term effects from IVF.
The follow-up questions are, though,
Yeah.
does it cause weight gain? Does it impact the immune system?
Weight gain, in the short term, it can, just within that IVF cycle. Typically, if you're responding robustly, you're going to get more fluid in the abdomen, and that will increase, you know, your weight, but it should go down at the end of the IVF cycle unless you get pregnant. Immune system. There's not great data on this, but probably it doesn't have a tremendous effect on your immune system in the short term. However, some people with infertility also have underlying autoimmune conditions, and depending on what that condition is, you might experience some changes during your IVF cycle.
Dr. Crystal, any idea on the percentage of marriages that fail because of the stress of failed IVF attempts?
There is no great data on that, and I'll tell you guys, honestly, as it relates to IVF and Black mental health, we are really behind on the research. I encourage anybody, historically, as it relates to research in the Black community, we don't get involved, and that is hurting us. So there are a lot of things we can't even speak to, or we can't even improve care for as it relates to the Black community. So there isn't any data on how many marriages survive, but I will tell you the stress, the trauma, if it goes unchecked, there is an increased rate of divorce, just generally, just because that is such a strain on the relationship.
I think we have time for a couple more questions. I'm in my early 30s and single, considering egg freezing. I got to give this answer to my daughter. Okay. What can I expect during this process?
Fantastic question. Okay, so number one, why might somebody freeze their eggs? So, you know, you are born with all of the eggs that you're going to have. There is a constant and then an accelerated loss of eggs during your reproductive life. And when you get down to about 1,000 eggs or less, no matter how hard your brain works, your ovaries are not going to respond anymore. We call that menopause. You're not releasing an egg anymore. That typically happens in our early 50s. But the end of our kind of reproductive lives is actually about 10 years earlier, so in the early 40s. That's about the last year or two that you'll be able to try to conceive on your own, and even then it'll be more challenging. Why is that? That's because the chromosomal quality, the genes within those eggs don't behave quite the same way that they did in your 20s and 30s. As we get into our mid-30s and certainly into our 40s, the way those genes within chromosomes divide, it doesn't happen the way it's supposed to. And if it doesn't happen the way it's supposed to, when the egg is fertilized, the embryo is chromosomally abnormal and typically won't implant or grow. So that's why you'll have ovulatory cycles. You might still be having a period, but if you are 43, 44, 45, the likelihood of you getting pregnant is very low on your own. Even with IVF, If you're 44 and doing IVF, the chances that it's successful, it's going to be around 5%. Okay? So freezing eggs is helpful to the extent that when you freeze the eggs, you're freezing the quality at that time. And in your late 20s to early 30s, the egg quality is the best that it can be. So if you are in your early 30s and considering going through an egg freezing process, what you can expect is about 2 weeks, about 10 to 14 days of injectable medications to help those follicles, fluid-filled sacs that have eggs inside of them, grow and mature. Then there's going to be a procedure, typically under anesthesia, where an ultrasound is placed in the vagina, a needle is placed through the back of the vagina to the ovaries to remove the fluid from those follicles, and an embryologist in another room looks through the fluid, finds the eggs, and prepares them to be frozen for future use. Those eggs can likely be stored indefinitely. We don't really know. IVF as a technology has been around about almost 45 years, since 1978.
I just love the way she's talking, don't you? She just says it so better. So let's talk about, is this costly? Does insurance cover this?
It is costly, in my opinion, and I'm
So
the person
insurance
doing
doesn't
it.
cover it?
Typically not. If you work
Okay.
for larger employers, especially in the tech world, they're starting to use this as a benefit to really recruit and appeal high quality candidates. So like, very large organizations may have coverage for egg freezing, but it's not part of the insurance mandate.
So how much?
Probably $10,000 to $15,000
Not per egg, per
cycle.
per cycle. Okay.
And you may need more than one cycle. The advantage of doing this when you're young, I know. The advantage of doing it when you're younger is that's when you typically have more eggs, so likely you won't need many cycles, but sometimes you might.
How many eggs could you actually get in that one cycle, though? How many eggs does it usually produce?
It varies a lot based on just your body and who you are, just the same way some of us have like really tight 4C curly hair like me, and some people have loose and wavy hair. Same thing with it when it comes to eggs. Some people are born with way more than the average number of eggs. Some people are born with way less. Everybody's different. So there isn't really an average, but to be successful, I would say you want to get somewhere between 15 to 20 eggs in a cycle. And in your 20s to early 30s, that's likely with one cycle.
Go ahead.
So I was actually going to ask a question to Dr. Amanda, Dr. Gloria, to hopefully give some practical advice to the audience, just to be more clear. By, say someone's single, they're not ready to have children, they're a professional, whatever the reason might be that they're delaying, what would you recommend as the latest they should freeze eggs, and how many, or even saying how many embryos? Is there advice around that? Because I think there's a lot of variation or lack of education in that realm.
So, early 30s, 30 to 35, because then again, the responsiveness of the ovaries really goes down drastically, quickly every year, like going off a cliff. So that time period is kind of that sweet spot. Usually people are, in their 25 to 30, they think everything's going to work out time-wise, so they're not really thinking about it. So really when that 30 comes along, then they start getting a little concerned and want to do that. So that's probably the time. What we're retrieving is all of the eggs that are going through that process and they're growing. So it's not like you say, take out 10, take out 20. They take all the ones that look good, and then they see if they're all viable after that. So some of them work and some of them don't work. And they're just in that one stage. So there's two parts of this. You can just freeze the eggs by themselves and then try to use that because you might not have the partner. But then the full IVF is freezing the whole embryo, so you have fertilization that's happened. And so again, you go through that, but you'll take the best embryo first when you try to do the cycles. So there's a timing part of it, and then there's a quality. So sometimes people have completed their family and they still have embryos left. So then they need to decide what to do with those embryos. Sometimes they will be adopted out to someone else who can't have a natural embryo, and then they'll carry those. And so it's really kind of an adoption in the uterus. So there are different things.
Last question, and then I want Reverend Dr. Stacy to wrap up for us. A couple of people touched on this. If you decide to go with a sperm donor, what advice do you give? Where do you go? Should you? How do you consider anything? Advice.
I love this question. So it depends on what you're looking for. As people of color in the audience, like myself, we might have a preference for a sperm donor of color. Maybe you don't, but often we do, and that's what I see in my office. There is a paucity. There are not very many black sperm donors. It's yet another issue that we face in terms of access. So if you are thinking about using a sperm donor and characteristics like that are important to you, you might want to start looking earlier than later. Also, the cost of vial of sperm from a sperm bank is usually around $1,000 to $2,000 per vial. If you're using that for intrauterine insemination, recall that the success rate's around maybe 10% per cycle if you're in your early to mid-30s, lower if you're older than that. For IVF, you can use one vial of sperm and that will work for your whole IVF cycle. But that cost of that sperm is not typically covered by insurance. So it's important to start thinking about these things early and planning. And then in terms of like where to go, where do you look? There's some big sperm banks. There's California Cryobank, Fairfax. I've heard, oh my gosh, it starts with an X. Zytec, I think might have more sperm donors of color, but there's, and then the Seattle Sperm Bank and the Sperm Bank of California. Those are kind of the big sperm banks where you might be able to seek options. There is also a way in which you could use somebody that you know. It is more complicated. From a regulatory perspective, we have to follow extra rules like quarantining the sperm, testing the donor, but it's not impossible if you have somebody you know who'd be willing. But then we also really want to get reproductive psychiatry or psychology involved because that relationship is going to be more complicated, and how you talk with your child about their genetic parentage and their family is special and needs to be done in an age-appropriate way. And I know Dr. Crystal probably has lots of thoughts about that.
Yes, I can't emphasize enough getting connected with a psychiatrist or psychologist early on in the process because these are huge issues that come up and are very complicated and can be very emotionally distressing. So I work with patients to really kind of play out, well, what does that look like? What are types of questions that may come up? How will you answer them? Almost in a role play. And what are your anxieties around these answers and these questions? And the better prepared people are, the more comfortable they are having the conversation.
Dr. Jennifer, to you, why are there not more sperm banks available for people of color? Where are the black men?
So the sperm banks are available.
But
We're just not going. We're making
So
appointments.
that's my real
Yeah.
question. Why are they not going?
To be real, some of it's fear, right? Fear that you'll have a kid out there. Fear that there may be some repercussions in the future. Fear of the social stigmas of the father not being in the life of the child. So some of it's, we need to communicate better. We need to communicate better with our communities. We need to recognize that this is a problem because we really don't talk about it enough. And I think once we're talking about it more, I think our men will donate a little bit more.
Lack of education as well?
Directly. I mean, this is not something, we're here now, but this is not something that we talk about every day. We all have girlfriends that are having difficulty that we don't even know about, but we feel that we're close to them. We just don't talk about it enough. It's one of those barriers. There's a lot of things we don't talk about. Things are much more open now than they used to be, especially a couple of decades ago. But this is serious. This is our future. These are our future children. We see how the demographics of the country are changing. If we're not also producing, it's going to change even more, and not particularly in our favor.
Reproductive.
And I think that in addition to sperm donors, there are not as many black female donors as well for donor eggs. And so, and the same issues exist, lack of education around it, concerns and fear. And And then what we're finding, and what I'm hearing from agencies, we're finding is that when our people make the decision to go, then there's some other challenges that exist around there, from backgrounds to them participating, whether it's, with alcohol, some doing drugs, is also impeding upon their ability to be able to donate. And so we do also, in addition to black male sperm donors, we also need women, young women, to donate as well. I don't know if you all know that if a young woman is able to donate, they can donate up to, is it 6 times? I think it's 6 times. And they can get between $8,000 to $15,000 for donating. Yep. $8,000 to $15,000 for donating. We see egg donation happening in other communities, and particularly Caucasian communities. These young women are paying off college debt, buying homes, putting money in their saving because they are donating. And sometimes they are getting more money because some of these women who are looking for donors are willing to pay more for blonde hair, blue eyes, certain, and so education. They're willing to go very far to get the persons that they want. But we are finding that young black women are not even donating. Some because they don't know anything about it. 2, because of the lack of education as well. I do want to also say that one of the things that we're seeing happening in some clinics, the doctors can kind of speak to it, is that some people are also doing shared cycles. And so what's happening is that in some of our clinics is that, say a woman is in need of an egg donor, and the egg donor is seeking to freeze their eggs. What they're doing is negotiating such that the person that is in need of the egg donor may pay for the cycle, and then what happens is that instead of the egg donor maybe getting money, they are able to freeze a portion of their eggs. And so what is happening is benefiting both the patient as well as the egg donor itself. But there are all types of options that are available to us. I think that it's just very important, again, that we get the information out and that we're educating our community around infertility and reproductive health, and even the options that are available to us on both sides.
I think that's fantastic, yes. Just to add on to what Reverend Stacey said, one company, and I have no relation to them, is Co-Fertility that manages that process of negotiating sharing of those eggs. Number 2, in terms of limitations, also a lot of the egg and sperm banks don't reach out to communities of color for recruitment. A lot of times if you're on the intended parent side, you want somebody who's like highly educated and looks like X, Y, and Z and whatever. So they're going to, standard, in a, I would say like white typical concept places that would be considered elite, right? So maybe the Ivies and whatnot, but they're not going to the fantastic HBCUs. They're not. So that's part of the problem is recruitment. I will say, having talked to some of the larger banks out there in the last year or 2, they've talked about recognizing this issue and making a change in recruitment. I'm too old. I don't know what they're doing on campus because I haven't been on a campus in 20 years. But supposedly that this is what's happening, is that they're starting to change the recruitment strategies. And the number 3, just so that everybody is aware, if you go to a reputable physician group or bank, there are actually legal protections for you. In this day and age, you will not be anonymous, okay? An offspring could do 23andMe and figure out who you are if you've happened to do it or you have a relative who's done it. So you should not go into the process thinking that this is anonymous. However, from a legal side, in terms of like what your obligations might be, although you might be a genetic parent, you are not the legal parent of that child. If you go through the proper channels, through reputable banks and reputable doctors, there are lots of checks and balances on this. So just as another point of education around addressing that fear that Dr. Jennifer and Dr. Crystal brought up.
This is fascinating.
I just want to be clear. I think what Dr. Amanda is trying to say, you will not be financially responsible for this child if they come back and find you on 23andMe or Ancestry or one of these other DNA websites.
Well, I almost hate to end on this note because I feel we have to do this again because I think there are a few more questions and stuff, you think? But thank you, ladies, so much. This was very, very educational. And Reverend Dr. Stacy, I'm going to let you wrap it up.
Well, let us thank our panel and our moderator. They were all amazing, weren't they? And thank you so much for your time and your commitment. And thank each and every one of you all for coming out today. Infertility and reproductive health is not an easy topic to have conversation. It's such a sensitive and personal conversation. And so we applaud you for your courage to come out today to support this discussion. I do want to remind you again that if you can fill that document out for us, it will be extremely helpful as we move forward to try to establish this National Week of Black Infertility and Reproductive Health. Fertility for Colored Girls will need all the help that we can get from all of our community partners and from each of you to help us to establish this day. I also want to say to you, this event today is a part of the research as well for our documentary that we will begin to film in January. Our goal is to take from our focus groups and from events like this, the information that is yielded to begin to shape the script for the documentary so that the information that will be shared from the documentary will really be community-led. I don't want it to be about what I want it to be about. I want it to be about what you want to hear about. So this documentary will be something that our children and our children's children will be able to use later on down the line. If you want more information about Fertility for Colored Girls, please check out our website. If you are looking for opportunities to serve or to work, we always need help. This organization is much bigger than I had ever thought it would be. We're in 17 states. And as we're preparing to do this documentary and as well as some of the other work that is wrapped around it, we always need help, we always need hands, and we always need support. If you are in need of a support group, please check out our website as well. And again, if you need any information at any time, Fertility for Colored Girls is here to support you. I want to real quickly thank all of our community sponsors. I have to say this before we leave because I do not take it lightly that each one of them agreed to be a part, to Advocate Healthcare, to American Society for Reproductive Medicine, for Cook County Physicians Association, for Delta Sigma Theta Sorority, the Chicago Alumni Chapter, to Delta Sigma Theta Sorority, Chicago Metropolitan Alumni Chapter, Amani Pearls Community Development Foundation, Lambda Pi Alpha Sorority, to Beta Mu Chapter Chicago, to the National Black Nurses Association Chicago Chapter, to the Bethel Church of Jacksonville, Florida, to the Center for Faith and Community Health Transformation, to the UIC Health, to Zeta Phi Beta Sorority Incorporated, Psi Psi Zeta Graduate Chapter. We say thank you to each one of you all for your support and commitment. And we also want to thank our own Trinity United Church of Christ, Imabasi Health and Wellness Ministry, along with our own no other than First Lady Monica Lynn Brown Moss for your support and partnering with us as well. Again, thank you so much, and please stay in contact with us. I also have books for sale. If you would like a book, Hold On to Hope, Stories of Black Women's Faith, Fertility, and Fight to Become Mothers. It's a wonderful resource. We'll have it outside. God bless you. May God smile upon you, and have a wonderful rest of your Sunday.
Thank you.